Okay, in our video series of gastroenterology lectures, in this video we are going to talk about hemochromatosis. We are going to talk about its clinical presentation, its diagnosis and management of hemochromatosis in detail. First of all, we have a case here. A 52-year-old man comes to your clinic complaining that, "Doctor, I have this generalized body fatigue for the last few months. I have been experiencing joint pains. Specifically, these two joints hurt the most." When you examine the patient, you find out that the patient has bronze skin discoloration. When you do the baseline test, you find out that the patient is having mildly elevated liver function tests. The patient also tells you that, "Doctor, 1 month ago I was also diagnosed with diabetes mellitus." Newly diagnosed diabetic, bronze skin discoloration with joint pains. This is the classical presentation of hemochromatosis. What is hemochromatosis? How does it present? How do we diagnose it? Today we are going to talk about that. So basically, hemochromatosis is a genetic or it can be an acquired disorder of iron metabolism characterized by excessive intestinal absorption of iron. So, hemochromatosis is an iron overload state where iron accumulates in the body, it accumulates in the joints, it accumulates in the organs, resulting in these symptoms. It affects individuals whose age is greater than 40 because it takes times, it takes years for the iron to accumulate in the body and cause its effects. And hemochromatosis affects women a bit later as compared to men because women menstruate, and during the menstruation they lose iron, they keep losing iron. Therefore, the symptoms of hemochromatosis in females appear later as compared to men, but usually it affects individual age greater than 40. Symptoms appear when the body iron levels are greater than 20 grams. So it takes years and years for the iron to accumulate in the body to produce its effects. Now coming to the classification of hemochromatosis, the classification of hemochromatosis is either primary hemochromatosis or secondary hemochromatosis. Primary hemochromatosis is the gene defect that causes hemochromatosis. The most important gene is HFE gene. HFE gene defect causes primary hemochromatosis, and it is present in people with HLA-A3 genotype present on chromosome 6. Another commonly tested point in exams is what is the disease transmission pattern. So it is an autosomal recessive disease and the mutation involved is C2A2Y. Now these are some important points if you are appearing in USMLE exams, because these genetic mutations are expected from a doctor who is appearing in STEPS exams. Another very important point is if you do not remember whether this disease is autosomal recessive or autosomal dominant, a simple way that I use to remember these is that if the disease involves the metabolic defect or any enzyme defect, then that is an autosomal recessive disease. It's not the case in all of the diseases, but most of the diseases that involve enzyme defects are metabolism defects. Those are autosomal recessive diseases. So hemochromatosis is the metabolism defect because the iron absorption is defective. If there is defect in the that affects the structure of the body, if there is a defect like osteogenesis imperfecta which affects the structure of the body, then most of these diseases are autosomal dominant. So in exam, if you're sitting and you do not remember whether this is an autosomal recessive or autosomal dominant disease, you can just use this technique, and in 80% of the cases you would mark the questions right, because there are always exceptions that do not follow this rule. Now, to understand hemochromatosis, you need to understand the role of hepcidin. Hepcidin is a hormone that is produced from the liver, and what hepcidin does is that it regulates the amount of iron that is being absorbed from the intestines. In the intestines, there are these channels called as ferroportins that allow the absorption of iron from the intestine into the blood and the body. Now, if there is excess of iron that is being stored in the body, or if body has sufficient amount of iron and body does not need any more iron, what hepcidin would do is that hepcidin would cause degradation of these ferroportin channels so that the ferroportin channels cannot absorb more iron from the intestines. Because the body is having sufficient iron, the body does not need iron, so hepcidin would block these ferroportin channels and would not let the iron be absorbed into the blood. So this is how hepcidin maintains a certain normal level of iron in the blood. The other organs that store iron are the liver and spleen. Hepcidin also regulates the amount of iron that is being released from the liver and spleen into the blood. So there are also these ferroportin channels that are present in these organs, and these organs are stores of iron and they leak iron into the blood. They throw away their iron into the blood so that there is a certain normal level of iron in the blood. So ferroportins are regulated by hepcidin. Hepcidin maintains a certain normal level and it does not allow the intestine to absorb excess of iron from the intestines. Now, what happens in hemochromatosis is that there is a gene defect, HFP gene defect, that results in decreased production of hepcidin. When the hepcidin production is low, the iron absorption from the intestine is not regulated. When the iron absorption from the intestine is not regulated, excess of iron will be absorbed from the intestines into the blood. There will be uncontrolled absorption of iron through the ferroportin channels into the blood. Because hepcidin caused this degradation of ferroportin channels, now the hepcidin is absent and these ferroportin channels will be active all the time. Even if there is excess of iron in the body, the ferroportin channels will be active because the hepcidin is absent. Now whenever there is excess of iron in the blood, that excess iron would enter the stores of iron. These stores are the liver, the spleen. There will be excess of iron in liver, spleen, and everywhere the iron is accumulating, it is causing oxidative damage to that organ. And that is how symptoms of hemochromatosis appear. So the main defect, the main problem lies in the hepcidin. The hepcidin production is reduced in hemochromatosis. Whenever there is decreased hepcidin, it cannot stop the ferroportin channels from absorbing excess iron, and that iron would be accumulating in the liver and in the spleen. So that was the primary hemochromatosis, where there was a gene defect that affected the iron absorption. Coming to secondary iron overload, secondary hemochromatosis. In the secondary hemochromatosis, there is a reason that is causing the iron to accumulate in blood, and that is most oftenly transfusion related. All those patients who receive continuous transfusions due to those blood disorders like thalassemia, sickle cell disease patients, these patients are receiving excess of blood transfusions, and those excess of blood transfusions would cause the iron to accumulate in the blood. Excessive alcohol consumption is also associated with secondary hemochromatosis because alcohol also increases the absorption of iron in blood. So that is the secondary hemochromatosis. Now coming to the clinical presentation of hemochromatosis. Clinical presentation of hemochromatosis is very easy to understand when you know the pathophysiology of the disease, how the disease is occurring. In the clinical presentation, the most common symptom, the most initial and most prevalent symptom the patient would come to you would be fatigue, generalized body aches, and arthralgias, joint pain due to iron accumulating in the whole body. Now, this is a very non-specific complaint. It's very difficult to diagnose a patient with hemochromatosis with these non-specific complaints. These patients might also come to you with impotence because these accumulate in the gonads and affect the gonads. These patients will have recurrent infections with organisms that love iron, like listeria, pseudomonas, and a very important high yield organism, especially for STEPS exam, is Vibrio vulnificus. On step 1, it is a commonly tested question that a patient is having Vibrio vulnificus infection. Patients had some seafood like oysters, and then after the oysters, the patient is infected with Vibrio vulnificus. Most likely this patient is having which condition? The patient is having hemochromatosis because Vibrio vulnificus proliferates wherever there is excess of iron, and hemochromatosis patients have excess of iron in their body. Now, these are very non-specific complaints with which patients might come to you. The specific complaints that you have to look for in these patients is that whether it is affecting the liver, because I told you that liver is one of the main storage organs of the body for iron. Whenever there is excess of iron accumulating in the liver, it would cause cirrhosis, it would cause hepatomegaly, and the most risky thing that you should fear, even in the absence of cirrhosis, patients can develop hepatocellular carcinoma. due to the chronic inflammatory process going on in the liver. Now, when it accumulates in the skin, it would cause bronze discoloration of the skin. This is how bronze looks like, and this is how a patient with hemochromatosis and a bronze skin looks like. This is a classical giveaway. Look at the eyes. These eyes are jaundiced. It means that the liver is also damaged. So by having a simple look at the face, you can see the pathophysiology, the ongoing damages. The liver is being damaged, accumulation of something in the skin, bronze color skin with liver damage. And most of the time what you would see is that these patients will be newly diagnosed diabetics. These patients will come to you and tell you that, doctor, 1 or 2 months back I was also diagnosed with diabetes mellitus because iron accumulates in the pancreas and causes pancreatic cell damage, and these patients cannot produce enough insulin to control the blood sugar. So newly diagnosed diabetic with a bronze color skin, with elevated LFTs, and this is a classical giveaway for a patient with hemochromatosis. One of the very important points that you need to remember is the second and third metacarpophalangeal joint pain. If second or third metacarpophalangeal joint pain is given in the MCQ stem, classical giveaway for hemochromatosis. Now, pancreas damage would cause diabetes mellitus. Now, there is another important clinical vignette that I would like to mention here. Newly diagnosed diabetic in a very old patient who is also a smoker. This is also a common vignette that you would see in your exam, and that vignette is for pancreatic cancer. A very old patient, newly diagnosed diabetic patient in their 70s or 80s, has been diagnosed with diabetes now and has been a lifetime smoker. That is a presentation of pancreatic cancer. That is also another important MCQ, another important point that you must remember. Whenever iron accumulates in the pituitary gland, it would cause hypogonadism, it would cause erectile dysfunction, loss of libido, amenorrhea. Makes sense because the pituitary gland is damaged, hormones are not being produced, and the patient will develop all these symptoms. Another very high yield and one of the most common initial presentation are arthralgias, joint pains, because it accumulates in iron and cause joint damage. Most common joints that are involved are metacarpophalangeal second and third one. It somehow does not affect first and fourth, but it mainly involves second and third. This is a classical giveaway point for you in the MCQs and in the questions. These patients of hemochromatosis are more prone to chondrocalcinosis, where calcium pyrophosphate accumulates in the cartilage of the joints. And if you look at this X-ray, you can see these white things, these white lines show chondrocalcinosis. What is chondrocalcinosis? I'll talk about that in a separate video, but you need to remember that hemochromatosis patients are also very prone to develop chondrocalcinosis, calcium phosphate deposition in the cartilages. When the iron accumulates in the heart, it causes cardiomyopathy, heart failure, cardiac arrhythmias. Another very high yield point is bronze diabetes. Bronze color skin pigmentation with newly diagnosed diabetics. This is called as bronze diabetes, classical giveaway for a patient with hemochromatosis. From an exam point of view, I really like these diseases like Wilson's disease, hemochromatosis, because these are very specific features that are very different from all other conditions. In real life, it is a bit difficult to diagnose these diseases, but on exams, it is very easy to pick up because no other disease have such features that these diseases have. Now coming to the diagnosis of hemochromatosis. Diagnosis of hemochromatosis, the initial test, it makes sense that we have to do iron studies. We have to see the iron levels. Serum ferritin shows the iron stores. The iron stores will be elevated and it will be greater than or equal to 200 nanogram per ml in premenopausal female and greater than or equal to 300 nanogram per ml for men and postmenopausal female. It is the bar is slightly lower for premenopausal female because these women are menstruating and are losing iron in the blood. But it is very rare to find a menstruating woman with the symptoms of hemochromatosis, because most of the time these patients develop symptoms after they go into menopause, when they stop losing the blood and iron actually starts to accumulate and produce its effect. So mainly you will see is that when the women go into menopause, after that you would see the symptoms, but in men you might see symptoms a bit earlier, like 10 to 15 years earlier than females. The transferrin saturation is high because there is increased iron in the blood. The transferrin saturation will be high, the serum ferritin will be high. If you find high serum ferritin with high transferrin saturation, this is highly suggestive that this patient is having hemochromatosis. And if in a patient you are suspecting that the patient is having hemochromatosis and you find normal ferritin and a normal transferrin saturation level, then has a very high negative predictive value. Because if the patient is having normal ferritin and a normal transferrin saturation, 97% of the chances are that the patient is not having the disease. So it has a high negative predictive value if these tests are normal. So you don't need to go ahead for any other costly testing of the patient, because these tests would tell you that you can easily rule out hemochromatosis. Now, if you want to confirm hemochromatosis diagnosis, the gold standard test is genetic testing. Previously, it used to be liver biopsy. Liver biopsy was done to diagnose hemochromatosis, but since we have genetic testing now, you do not need the liver biopsy. You just need to test for HFE gene if the patient is having higher ferritin, high transferrin saturation with the symptoms of hemochromatosis. You just need to confirm with genetic testing. In the past, it used to be liver biopsy, but it has limited use now because you can easily see the condition of liver on non-invasive tests like MRI abdomen without contrast. On liver biopsy, you would stain it with the Prussian blue stain. On the Prussian blue stain, you would see hemocydin appear blue. Now, coming to the treatment of hemochromatosis. For the treatment of hemochromatosis, it depends whether it is primary hemochromatosis or secondary hemochromatosis. In the primary hemochromatosis, mainly the first line of treatment is therapeutic phlebotomy. Therapeutic phlebotomy means that you take out the patient's blood because the patient's blood is having excess iron. You remove excess iron by removing the blood. That is called as therapeutic phlebotomy. What you do is that on the initial stages, you take 500 ml of blood removed weekly over 1 to 2 sessions, and the goal is that you remove it till you achieve a ferritin of 50 to 100 nanogram per ml. And then after that, what you do is that you remove 500 ml of blood 3 to 4 times per year. So that is called as therapeutic phlebotomy, where you remove the patient's blood so that you can remove the excess iron. The goal ferritin is somewhere around 50 nanogram per ml. If in hereditary hemochromatosis, if the phlebotomy fails to achieve the target ferritin, then iron chelation therapy is used. In iron chelation therapy, you use certain chelating agents. Chelating agents are the agents that bind iron and remove iron from the blood. These agents include deferoxamine, deferoxyrox, and deferriprone. The main and the most important one that you need to remember is deferoxamine, very commonly used. Now, if the phlebotomy fails in hereditary hemochromatosis, you can put the patient on iron chelation therapy, where these agents would bind the iron and remove them from blood. Now, in secondary hemochromatosis, like the patients with thalassemia or the patients who are having iron overload due to excessive blood transfusions, in such patients, iron chelation therapy is the first line therapy, because these thalassemia patients are already blood deficient and you cannot remove any blood from these patients. So in patients who are already blood deficient, like thalassemia patients, in these patients you would do iron chelation therapy as a first line treatment. For hereditary hemochromatosis, the first line is therapeutic phlebotomy. For secondary hemochromatosis in patients with thalassemia, iron overload, iron chelation therapy is the first line treatment. Now, before giving iron chelation therapy, you must check renal functions, because iron chelation agents are nephrotoxic. Now, the patients of hemochromatosis would develop hepatocellular cirrhosis, hepatocellular carcinoma, a very bad complication. If the patient is having decompensated cirrhosis or hepatocellular cirrhosis, you can go for liver transplant. Untreated iron overload is not a contraindication for liver transplant in these patients. These patients can go for liver transplant even if they have untreated iron overload. Lifestyle modifications include that they have to strictly avoid alcohol, because one, alcohol increases iron absorption. Second, alcohol is hepatotoxic. These patients' liver is already having much of toxicity due to iron. You do not want more toxicity through the alcohol. These patients have to avoid iron or vitamin C supplements. Why do they avoid vitamin C supplements? Because vitamin C causes absorption, excess absorption of iron. Usually, what you would see is that those patients who are iron deficient are prescribed iron supplements, and with iron supplements, vitamin C is also prescribed. A very common MCQ question as well, that why vitamin C is prescribed with iron? Because vitamin C increases the absorption of iron. Therefore, you have to avoid iron and vitamin C supplements. But what about the normal diet? If there is a normal amount of iron that is present in the normal diet, there are no dietary restrictions in these patients. These patients can just have normal diet. They just don't have to take these supplements of iron. PPI has shown to decrease iron absorption. So if a patient is having GERD and the patient is also having hemochromatosis, it's a good idea to start proton pump inhibitors in these patients. If the patient is not having GERD and the patient is having hemochromatosis, then you should not start PPI just for the sake of decreasing the iron absorption. Only if both of these are present, then you have to start PPIs in these patients. Now, before going into the summary, if you liked my video, please click on the subscribe button. We talked what is hemochromatosis. It presents later in females. The primary one that involves the genetic defect, secondary with the recurrent transfusion, the role of hepcidin. Hepcidin stops ferroportin from absorbing excess iron. When the hepcidin levels are low in hemochromatosis, excess iron is absorbed from the intestines. The clinical features, how does it affects various organs, bronze, diabetes, newly diagnosed diabetic bronze, skin, elevated LFTs, pain in second and third metapharyngeal joint, classical features of hemochromatosis. Iron studies are done, genetic testing is the gold standard, therapeutic phlebotomy first line in hereditary hemochromatosis, iron chelation therapy first line in patients with secondary hemochromatosis. Liver transplant is the treatment. What are the lifestyle modifications? If you liked my video, please make sure to click the subscribe button and make sure to check out my other lectures on gastroenterology, ECG lectures, and emergency medicine lecture. I have various playlists on different lectures. You can check them out on the links given in the description below. Thank you very much.